Hello, I'm Shareefa Fahima, Assistant Professor cum Clinical Physiotherapist from Yenepoya Physiotherapy College, Yenepoya deemed to be University, and I'm here presenting y'all a session on Duchenne Muscular Dystrophy. The specific learning objectives for this session that the listener will be able to understand is that they'll be able to explain and classify types of muscular dystrophy, understand the clinical manifestations of Duchenne muscular dystrophy, and identify the role of physiotherapy rehabilitation for this condition. Muscular dystrophy. This word denotes that it's a group of conditions that undergo progressive degeneration, and the patient or client who inherits this condition gets progressively weaker without involvement of the nervous system. That means any patient who has this condition, by years or months or days, they get more and more weaker. These are the classification or types of muscular dystrophies based on the onset. Okay, we have earlier childhood onset, youth or adolescent onset, and adult onset. Early childhood onset, we have Duchenne muscular dystrophy, Becker muscular dystrophy, congenital muscular dystrophy, and Emery-Dufus muscular dystrophy. Based on youth or adolescent onset, we have facioscapulohumeral dystrophy, limb girdle muscular dystrophy, and based on adult onset, we have discal muscular dystrophy, myotonic muscular dystrophy, and oculopharyngeal muscular dystrophy. This is an image describing the various patterns of weakness in the various types of muscular dystrophies. In the first one, we have Duchenne muscular dystrophy, where there is involvement of the hip, of the thigh, the shoulder region, and the neck muscles. We have Emery-Dufus muscular dystrophy, similar to the first one, but there is involvement of the heart and the back muscles. Congenital muscular dystrophy, where there is involvement of the whole body. Limb girdle muscular dystrophy, where there is involvement of the two major limb girdles, that is the shoulder and the hip girdle. Facioscapulohumeral dystrophy, where there is involvement of the face and the scapular muscles, and oculopharyngeal muscular dystrophy, where there is involvement of the ocular muscles, that is the eye muscles. In this, I am going to explain the major type, that is Duchenne muscular dystrophy. Now, this is also called as pseudo-hypertrophic muscular dystrophy. Pseudo meaning it is a false hypertrophic of a muscle. Okay, it is also called as progressive muscular dystrophy. That is because it's a progressive condition. It is one of the most prevalent and severely disabling of the childhood muscular disorders. It is a dystrophinopathy in which the child becomes weaker and usually dies of respiratory insufficiency or heart failure due to myocardial involvement. Okay, in this dystrophinopathy, this refers to a spectrum of disorders where dystrophin is involved. There is mutation in dystrophin protein. Okay. Now, in this type of dystrophinopathy, here the child becomes weaker and weaker, and at the end stage, they usually die because of any kind of respiratory insufficiency or involvement of the heart, where the heart muscles get weaker. So, defect in a single protein in this is a dystrophin. Now, this protein is usually important for contraction. It's a link between the muscle and the extracellular matrix. So, it is very important for contraction. So, then there is any kind of mutation in this protein, usually there is something called as dystrophy, the spectrum disorders that occur, and one of the type is Duchenne muscular dystrophy. Clinical features can be divided into motor related and non-motor related. Motor related clinical features will be abnormal gait involving, that means the walking pattern is abnormal, where the child or the client attempts to walk as toe walking on the toes, or there will be a waddling kind of gait. Next, there is calf pseudohypertrophy. At the calf muscles, there is pseudohypertrophy. That means there is false hypertrophy. Usually, whenever there is hypertrophy of muscle, the muscle bulk is increased. But here, it is a false pseudohypermuscletrophy. That means instead of the muscle bulk, there is deposition of fat present over here. That's why it is a false hypertrophy, calf pseudohypertrophy. There is decreased endurance. There is decreased head control when pulled to sit because involvement of the neck muscles. There is difficulty in climbing stairs. There is flat feet. Okay, usually in your feet there is an arch present over here, but because of weakness of the muscle, this arch gets flattened. So flat feet is present. There is hyperlordosis. The normal curvature of the back is more in this condition, so that's called as hyperlordosis. Other features are, there is frequent falling or clumsiness because of weakness. There is something called as Gower's sign present on rising from the floor. That is this. In this, the child, instead of getting up using his thigh and calf, they try to use their hands to get up. Okay, they'll try to use their hands to get up, to push their knees and then try to stand up. That is known as Gower's sign. There is gross motor delay in all the function, that is walking, running, jumping. There is delay in all this. Hypertonia, reduced tone, inability to keep up with their peer groups. Okay, when all the other child, they walk, they run, they climb stairs, these child tend to be slower in doing that. There is loss of motor skills, there is muscle pain or cramping, toe walking with waddling kind of gait, and difficulty running or climbing. These are usually the muscle groups that are affected. We have plantar flexors and evertus, quadriceps and gluteus muscles, long extensors of the hand in the upper side, biceps, triceps, deltoid, pectoralis, latissimus dorsi, and some shoulder girdle muscles. Non-motor related clinical symptoms. The client usually has behavioral issues. They become inattentive or hyperactive or are not able to regulate their emotions, failure to drive or poor weight gain, learning and attentional issues, speech delay or articulation difficulties in the later stage, and yet they have cardiomyopathy, that is weakness of the heart muscles. So this is how the whole disease is staged as it is a progressive condition. This is how the whole disease would be categorized. Stage 1, you have ambulatory phase, where the baby or the client has Duchenne muscular dystrophy, but they are able to walk, able to ambulate. Stage 2, they ambulate, but they have difficulty in climbing the stairs. Stage 3, they can come to stand from sitting position. Stage 4, they need to be lifted by someone to stand, but they can walk only with support. Stage 5, wheelchair independent. They do most of their activities using a wheelchair. Stage 6, wheelchair dependent. They are completely dependent on the wheelchair for their mobility. Stage 7, they are confined to a bed. They are bedridden, but they are independent here. That means they might be able to do some of their activities like feeding, eating. Stage 8, they are confined to bed and dependent on all ADLs. So next in the block, we have the age categories or the timeline for it. Stage 1, 2, 3 and 4 and 5 takes up to 7 years. Stage 6 and 7 up to 12 years and stage 8 up to 19 to 20 years. This is another classification, ambulation function classified for DMD. Here it has 5 classification. It's similar to the previous one. Here level 1 denotes that they are able to walk in normal speed and posture. Level 2, they walk independently without any assistive devices or brace, but some kind of abnormal pattern has started. For example, the gait. You can see there is tiptoeing, there is waddling, and there is also hyperlordosis seen. In stage 3, they can walk only short distance using some kind of assistive devices. Stage 4, they cannot walk, need to use a powered mobility or a wheelchair. Stage 5, they are transported in a wheelchair and completely dependent on it. Now let's see what is the physiotherapy management for each stages of this condition. We have the ambulatory stage. The patient can walk the stairs. Here, early detection and management of contracture is a single most important step to keep the child walking and mobile. So how do you manage this contracture or prevent them? Positions which encourage contracture formation should be avoided. Positions such as long leg sitting, prone lying are encouraged so that they stretch the hamstrings and the hip flexors, which are prone to get contractures. Passive stretching should be done daily or active stretching. Standing and walking are functional stretching exercises. Splinting, especially at night, should be done to avoid any kind of contractures. Any kind of AFOs, ankle foot orthosis, should be used. Endurance exercises, respiratory muscle strengthening exercises such as chest physiotherapy, any kind of breathing exercises. BiPAP ventilation may be used at night. This helps in ventilation, this helps in breathing. Monitoring and prevention of any cardiac complications. Psychological support to the patients and their family. Wheelchair dependent stage. Okay. Once they reach this stage, here their major focus will be on respiratory management and training, management of any acute episodes of respiratory insufficiency, any kind of infections, breathing exercises and endurance training, and any use of assistive ventilation. Here, orthoses are more common, such as mobile arm support, forearm orthosis, or any kind of overhead sling suspension system can be used for upper limb weakness. All the everyday devices can be modified. Assistive devices like long handled combs, reachers and spoons, modified toilets are required. So all the ADLs that they usually do can be modified for their preference. Prevention of scoliosis is critical to sitting balance and comfort in a wheelchair and respiratory function. So usually when the baby starts using the wheelchair for a long period of time, they are prone to get scoliosis. So how do you prevent that? We prevent that by making sure that the wheelchair has modifications such as lateral trunk supports, custom made spinal support systems which can help relieve from pressure sores also, and improving the respiratory functions, and also early bracing. Standing therapy for at least 3 hours per day is required in divided periods so that they do not get fatigue. Hydrotherapy can be used. Eating habits also should be supervised so that they prevent obesity, as they're usually in wheelchair without any kind of physical activity. They tend to be obese, so that has to be monitored. And cardiac function monitoring should be done at regular systems, because usually the baby or the client tends to die because of cardiomyopathy in later stages. So each time you have to monitor for it. Stage of prolonged survival. Now ambulatory stage is done. In case you're not able to maintain that, you have the wheelchair dependent, and now this is the last stage. In this stage, physiotherapy helps in the use of non-invasive respiratory muscle that helps in ventilation. We have to help them in clearing airway secretion, because they're prone to get infections, because they'll be bedridden for a long period of time. Facilitation of ADL independence as far as possible. That's how the last slide we spoke about long handles, combs, and modification of the toilet, so that they are able to do their ADLs independently. ADLs refer to the everyday activities, and communication aids wherever possible. Example, personal computer with voice synthesizer, eye twitch control can be used for communication. So a summary of all this: muscular dystrophies are a group of conditions that undergo progressive degeneration without involvement of the nervous system. Year by year, the condition deteriorates. Defect in dystrophin causes DMD. Dystrophin is a protein that is required for contraction. If this dystrophin is mutated because of any reason, that causes DMD. Clinical manifestations are in the form of motor and non-motor symptoms. Motor symptoms related to the muscle weakness, non-motor related to the behavioral issues, cardiomyopathy, learning disorders. And physiotherapy at different stages of this disease helps in providing proper treatment program that aims in maintaining the functional capacity of the individual and preventing any kind of secondary complications such as contracture. These are the references. Thank you.